Hello, and welcome to Optimizing Outcomes of JAK Inhibition in Myelofibrosis, Practical Considerations for the Clinic. I'm Raajit Rampal from Memorial Sloan Kettering Cancer Center in New York, and I'm joined by my good friend and colleague, John Mascarenhas from the Mount Sinai School of Medicine. So this is a touch-in conversation activity, and today we're going to discuss optimizing outcomes of JAK inhibition in myelofibrosis, and really to focus on the practical considerations for how to utilize JAK inhibitors. We'll begin by talking about what are the key considerations when selecting a JAK inhibitor for first-line therapy in myelofibrosis. So as a backdrop, when we think about myelofibrosis, we are thinking about this as a spectrum of disease. And there are patients who are going to do well for a decade or more, and there are patients who are going to have progression of their disease early on. How do we prognosticate that? Well, we have several prognostic models that we can use. And these tools can really roughly be divided into two categories. There are tools that rely principally on clinical characteristics, and then there are those that now incorporate molecular diagnostics, which we think gives us a little bit more of an enhanced way to look at prognosis. In regards to the tools that we have that use the clinical characteristics, we have the International Prognostic Scoring System, or IPSS, which is meant to be used at diagnosis only. And then we have the DIPSS and the DIPSS Plus, both which can be used at any time during treatment. The components that really are in all of these scoring systems include an age greater than 65, the presence of blast cells in the circulation, and the amount of blast cells really varies in terms of their impact in the different scoring systems. The presence of constitutional symptoms, the presence of mutations, of driver mutations or other mutations in the molecularly driven scoring systems, the presence of anemia, the presence of thrombocytopenia, principally in the DIPSS plus, and an elevated white count of greater than 25,000. So we identify patients who are in low risk, intermediate, or high risk for disease progression. In terms of how we treat patients, it's important to realize that the IPSS and the DIPSS scores don't actually tell us how to treat the patient. Rather, they tell us about the prognosis, and in many ways, they can inform whether or not we should think about a stem cell transplant. But as it pertains to JAK inhibitors, when we think about how to treat patients, if somebody has spleen or symptom issues and their platelets are over 50,000, then we think about the use of JAK inhibitors. And currently, 2 JAK inhibitors are approved for patients with a platelet count of greater than 50,000. Those are ruxolitinib and fedratinib, and we're going to talk about those in detail in a few moments. And for patients with a platelet count of less than 50,000, pacritinib is now FDA approved to be used in this setting. And of course, we always want to think about clinical trials given the natural history of this disease. So, John, a lot of things to consider here. First question maybe is, what are the factors that you consider when choosing between the 3 different approved JAK inhibitors that we've talked about and the first-line treatment for patients with myelofibrosis?
So I think probably the most obvious node of decision-making is what is the platelet count? Platelet count really determines the initial consideration for JAK inhibitor therapy. So less than 50,000, pacritinib is clearly the only drug that's approved in that patient population. So that's an easy one. I think it gets a little bit more tricky when it's 50 to 75,000, 50 to 100,000. One could use pacritinib based on the PERSIST-2 data, but one could use ruxolitinib approved in 2011 with data in the 50 to 100,000 range, but also fedratinib, which in the Jakarta studies allowed for patients with 50,000 and greater. So there is overlap there in that patient population, but platelet count really determines the initial thought process. And then considering the toxicity profiles may differ a little bit, so there is more on-target GI toxicity with the FLT3 inhibition pathway seen with both pacritinib and fedratinib. So if I have patients who have serious concurrent GI illnesses, maybe IBD, IBS, things that might already be problematic, that might influence my decision-making in terms of GI toxicity. But generally speaking, I think platelet count is really the determining factor. And increasingly, we're paying attention to anemia. And there is data that pacritinib does have an anemia response. And of course, the community is expecting an approval for momelotinib, in which there is data for anemia responses, but we don't know what the label will look like. So I would still say in 2023, platelet count is probably the deciding factor for selection of a JAK inhibitor.
Great. No, and I totally agree with that. And obviously, patients' comorbidities and to some degree preferences. Another question that I think comes up frequently is what's the ultimate goal of JAK inhibitor treatment in myelofibrosis, and is it different for different patients?
I think it might be different for different patients because the reality is patients are quite different. When you encounter patients with myelofibrosis, they rarely look the same. There's a lot of variability and heterogeneity in the way they present, their clinical course. So the treatment does have to be tailored for what that patient is experiencing. For some patients, it's mostly spleen and spleen-related complaints. For other patients, it may be systemic symptoms. And for some patients, it could be both. And then there are a subgroup of patients where they really are more of a bone marrow failure state, almost like an MDS picture, where anemia is really the treatment goal and less spleen symptoms. So you have to tailor, and that really just requires a conversation with the patient. What is the treatment goal? Set expectations, reasonable expectations, and then talk through the timeline or the kinetics of expecting response, and then the potential for toxicity that might offset some of that response. I think for the most part, we give JAK inhibitors to reduce spleen and improve symptoms, and that is typically the primary and secondary endpoints of these pivotal studies. I'm always cautious not to oversell the idea that there's a survival benefit with these drugs. Although I do believe there's a survival benefit, it is not for the classic reasons in oncology where one gets a histopathologic remission, a complete molecular remission. The bone marrows, for the most part, stay the same. So we're really looking at probably survival benefit that is driven by improvements in symptom burden, performance status, reversal of cachexia, and patients who move and eat are likely to just live longer than patients who don't. There is probably some effect from the anti-inflammatory component of these drugs that probably does offset some disease-related progression, but unfortunately, it's very hard to measure, as you know very well. So, although I do point out that patients who are treated with JAK inhibitors are likely to live longer than patients who don't, it's not really the primary reason that we prescribe the drug.
So I think it's maybe safe to say MF is not a monolithic disease, and JAK inhibitors are not a monolithic category of drugs. Next question that also is, I think, important how we think about these drugs are, what are the key efficacy data and dosing considerations, importantly, as they pertain to platelet count, right, for the approved JAK inhibitors, and how does that influence your choice of treatment?
Well, I mean, we have some differences for sure amongst these JAK inhibitors. So ruxolitinib is probably the most complex in terms of dosing, as there are doses of 5, 10, 15, 20, and 25 milligrams that are based on the platelet count. And I really don't think that most prescribers really utilize the FDA label and nomogram for platelet. There were, in the clinical trials that were the pivotal trials that led to the approval, there were instructions for how to dose based on platelet count. I typically will use Rux at a low dose and then titrate up to try to maximize JAK inhibition through spleen reduction as the clinical outcome measure. Sort of realizing that we are going to get treatment emergent thrombocytopenia, that ultimately limits the ability to raise the dose to some extent. Now, what's interesting is, and of course it's a BID dosing, what's interesting is fedratinib at 400 milligrams daily, which is the approved dose, can be used whether your platelet count is 55,000 or 455,000. It does, allow for some ease of administration, and it comes as 100 milligram capsules. So you prescribe 4, capsules once a day, with a heavy meal for absorption purposes, and that does provide a little bit more ease of administration, and that's a consideration when dosing patients with fedratinib. We still got to follow the platelet counts. You can see that there's still some treatment emergent thrombocytopenia and anemia that does occur with fedratinib. That actually looks not too dissimilar from ruxolitinib, I would say. And then for pacritinib, it's also a fixed dose of 200 milligrams twice daily, and that is approved for less than 50,000 platelets. So you're really using it at the full dose, and the studies would suggest you maintain dose intensity no matter what the platelet count is, because you do not get the same degree of thrombocytopenia. So one needs to be aware of the dosing, but follow the patients and their counts, and be prepared to potentially dose modify based on counts. I would also say treat through cytopenias too, and I think that's a common mistake that's made in the community, in which the hemoglobin drops, particularly with ruxolitinib, for example, in the first 2 to 3 months, and the tendency is to really pull back on the dose, and you sort of you compromise the activity of the drug, and the idea is to try to maintain the dose, maybe transfuse through that period, because usually the hemoglobin will settle down about 1 gram per deciliter from where you started. So sort of understanding the on-target treatment effects might also help optimize the delivery of the drug.
But as you said, optimization is key, as is dose intensity. So being aware of the side effects and knowing when you can treat through them is obviously an important point here.
Yep.
Right. So now we'll take a look at some questions that were submitted by the audience during our discussion. So first, is there an optimal time to initiate JAK inhibitor therapy to optimize patient outcomes and reduce risks? Certainly, this is a really challenging issue.
So I don't think we know the answer to that fully, actually. I mean, I think we tend to use, as you pointed out, the risk stratification tool. So higher risk patients are patients that we would consider for JAK inhibitor therapy. I would argue, though, if you have a low risk patient who's quite symptomatic, maybe with bone pains that may not trigger an upscore in their prognostic scoring system, and or fatigue, which can be MF-related symptoms, you may employ a JAK inhibitor, even in low-risk patients. So I think being aware of the symptom burden, aware of the spleen, sort of dictates the need for JAK inhibition. The optimal timing, may be as early as possible, actually. We don't know that for sure. If you look at the survival outcome data from the COMFORT studies, it would suggest that the earlier you start the JAK inhibitor, ruxolitinib in that case, the better the survival impact. There was a study called the RETHINK study that was done a number of years ago in the UK. Unfortunately, that study stopped due to low accrual, but it was an important study that was looking at whether one should be treating lower risk patients with high molecular risk features earlier on to sort of optimize the effect of JAK inhibitors, maybe prolong the durability of response. So I think it is common that patients often, maybe less so today than 10 years ago, but are often delayed in starting a JAK inhibitor. So I think it's important to have that conversation and be, again, realistic about the potential benefits, but also the potential toxicities and the expectations of goals of therapy. But I would say probably in most patients, earlier on in the disease course is probably where you're going to optimize JAK inhibition.
Right. And coming back to, again, the principle from the beginning, which is that the IPSs and the IPSs are not the things that tell us when to initiate therapy. An important point.
Hello, everyone. My name is Eduardo Franco. I want to welcome you back to this educational activity